So, shall we start?
Yeah, we'll go ahead.
Okay. Good afternoon to one and all present here, and welcome to your favorite channel in understanding cancer, Cancer Reach. Cancer Reach is an initiative by our very own healing hero, Dr. Krishnamani, to spread awareness about cancer and to help patients and caregivers access the right treatment at the right time. Without much further ado, let me introduce our healing hero so he can enlighten us on today's topic, which is on colorectal cancer. Dr. Krishnamani completed his medical graduation in 2005, his post graduation in 2010, and he has specialized in medical oncology in 2014. Since then, he has continually expanded his knowledge and skills by completing fellowships from prestigious international institutions. He has been actively involved in academic contributions and professional development. He has participated in numerous seminars and meetings and has presented papers at both national and international scientific forums. Currently, he is working at American Oncology Institute in Hyderabad. A very warm welcome to you, sir.
Hello, welcome all to Cancer Reach. And as always, Cancer Reach is an initiative to spread awareness on cancer. And today, the point is we are going to discuss a few things on colorectal cancer, and which is a common cancer, and we are going to take it forward.
So, sir, can you start by explaining the name colorectal?
See, colon is your large intestine. Okay, the rectum is the lowermost or the final part of the large intestine. So colon starts from the colon is a large intestine which starts from the ending of the small intestine. So it starts from the ascending colon, we say it goes up, then it takes a bend. It is called the transverse colon because it is transverse, and then it goes down, which is called the descending colon, and then the rectum. So ascending colon or the right side of the colon, transverse colon, descending colon, which is the left side of the colon. That is your colon. A cancer which comes here is the colon cancer or the colorectal cancer. In simple terms, a large intestine cancer.
So, how is it caused? Like, what are the causes for it?
See, some of the causes are smoking is an important cause. Okay, there are certain carcinogens which are causes. There are certain diseases like Lynch syndrome, which is called hereditary non-polypotic colon cancer. There is another disease called familial adenomatous polyposis, in which if you some many people in the family are affected. They are all affected at a very young age, below 40 or whatever. Their colon is filled with more than hundreds of polyps. That is called FAP, familial adenomatous. The non-adenomatous or no hereditary non-polyposis colon, HNPCC, is called Lynch syndrome. They have a mutation in a particular gene. Hmm. Colon cancer can also be a syndromic association in other can be seen as other cancers too. So, and it is one of the most, age is an important factor. Once you cross the ages of 40, 50, the risk of colon cancer increases. Men more than women. The incidence is slightly higher in men compared to women. So these are some of the factors we see which cause colorectal cancer.
Sir, you have mentioned that people in the family would have it below the age of 40 years. What is the incidence like? How many cases do you see where patients are diagnosed below 40 years of age?
So I would not have that number directly, but if you have some 10 patients with colorectal cancer, you would probably see two or three below 40 or below 50. Okay, I'll just give you a small example. The other day we had a gentleman who is in his mid 30s. We had treated his aunt for some cancer. So he keeps coming to the hospital on and off for checkups for his aunt. He came to me saying that I got a master health checkup done. I'm completely fine. I have no problems. My CEA level is 37 or something. So CEA is a blood marker. It is elevated in colon cancer, not in all patients. It can be elevated in normal people also. For him, the CEA was 37, which is high. Then I said, uh, fine, but you are asymptomatic, you are in your 30s, there is no family history of cancer, so why should we worry? So, an interesting point he made, he said, I eat well, I eat home food, I eat non vegetarian food also. but my hemoglobin is not going up beyond 9 or 9.5. So a young male who has a very good appetite takes non-vegetarian also. If you are vegetarian, at least I can say you are B12 deficient. That is also not there. You have anemia and you have a raised CEA. So that prompted us. We said, okay, just get an ultrasound abdomen. And there was a large mass sitting in the colon. We did a colonoscopy. There was a growth. We did a biopsy. It came as cancer. It was then a scan was done, CAT scan. It had not spread anywhere. He had a surgery done. It has come as stage 2. So what I'm trying to tell you is patients can come with no symptoms, with symptoms too. Just a rise in CEA. Okay. And some patients can be young as him. We also see quite a few young patients who come with advanced disease. See, the younger the age, generally, the disease is more aggressive. So, the number wise, the patients who are below 40 would be 2 out of 10 or 3 out of 10. But surely that number is increasing because more people are getting evaluated themselves. They get master health checkups done, they do these tumor markers, they do ultrasounds regularly, and they are more aware now.
And so, like, what would be the most common signs and symptoms for colorectal cancer?
Bleeding in the stool, alternating constipation and diarrhea, loss of weight, loss of appetite, tightness in the abdomen, feeling a sense of fullness. Yeah. And after that, if it spreads to the other organs, if it goes to the liver, you may have jaundice. If it goes to the bone, you may have bone pains, so on and so forth. But more commonly, blood in the stool, alternating constipation, diarrhea, losing weight, losing appetite.
How would you go about with diagnosis of colorectal cancer?
See, the first thing is test to confirm a diagnosis. So, how do you confirm? You will do a colonoscopy or a sigmoidoscopy. That is a small tube with a camera which is put inside the colon. You prepare the bowel. So the previous day itself, the patient is given a lot of laxatives so that he or she passes a lot of stool, so that the intestine is very clearly visible to see for the endoscopist or the gastroenterologist. They put the scope, they see wherever there is a lesion or an ulcer, they take a biopsy. So I will do a test to confirm my diagnosis, which is a colonoscopy and a biopsy. Then, once it is proven as cancer, I'll do test to stage the disease. Staging is with a CT scan or a PET CT scan to see where all it has spread. Colon cancer can spread to nearby lymph nodes or commonly goes to liver or lung. So a CT scan or a PET scan will tell you that, or an MRI. Then I will do tests to support my diagnosis. One is a CEA, carcinoembryonic antigen. It can be elevated in colitis, infections, Crohn's disease, so non-cancerous conditions. It can also be normal in colorectal cancer. It can also be elevated in other cancers. So just a raised CEA doesn't mean you have colorectal cancer. It will only support my diagnosis. It can be normal also. Then I will do routine tests to evaluate the health of a patient, like hemoglobin, WBC, platelet, kidney function, liver function test. So, test to prove my diagnosis with a biopsy and a colonoscopy, test to stage the disease with a CT scan or MRI or PET, test to aid my diagnosis with a CEA or a tumor marker, tests to assess the general fitness or health of a patient by CBC, RFT, LFT. These are the things you have to do.
Sir, like for Indian patients, are there any other genetic tests which are done to see for any mutations or any other
So we do,
causes?
if you have HNPCC, you will be tested for germline for Lynch syndrome. We say germline is testing the blood for Lynch syndrome. The tumor itself is assessed for microsatellite instability, we say. FAP, we test for a chromosome 5P. You test for that on the tumor specimen. So these are all the tests you do to look for any genetic association.
So we have done the diagnosis and we have done the staging also for the patient. What would be the next step? How do you determine whether the patient goes for chemotherapy or whether it will go for surgery first? How do you decide that?
Great. So now you should know the stage now. Stage 1 is T1, T2, lymph node negative. So TNM, T1, T2, N0, M0, no nodes, no metastasis is stage 1. Stage 2 means T3, T4, node negative, metastasis negative. Stage 3 means node positive. Stage 4 means M positive, metastasis. So come backward. Stage 4 means M1. Stage 3 means node N1. Stage 2 means T3, T4, node negative. Stage 1 means T1, T2. So based on your scan, if you don't have metastasis, go for surgery. I'm talking about colon cancer, not rectal. We'll today discuss only colon for some time. So if you do a PET CT, there is no spread to liver, lung, bone, brain. There is or there may not be any lymph nodes. Even if there is lymph nodes around the colon or there are no lymph nodes, take him up for surgery. Surgery, after you do the surgery, after 1 week to 10 days, you get your final histopath report. Metastasis is already not there. M is 0 because PET CT is normal. That histopathology report will say what is the size of the tumor, what is the site, right side or left side, grade of the tumor, whether it is involving lymphovascular invasion, any nerve, perineural invasion. These are all the components of the report. The pathologist will tell you size of the tumor, site of the tumor, lymphovascular, perineural invasion, grade of the tumor, number of lymph nodes. You should remove at least 15 lymph nodes. If you remove 5 or 8 lymph nodes, you have done an incomplete surgery. So out of the 15, how many are positive? All are negative, or all are positive, or some are positive. This is your final histopathology report. Now, if the pathologist says it is T2, 0 out of 15 positive, that means T2N0, that is stage 1. If he says it is T4, 0 nodes, T4N0, stage 2. If he says T1, but 5 lymph nodes, I'm just giving you an example. T1, 5 lymph nodes positive, that becomes N2 disease, that is stage 3. So my final stage is based on surgical specimen, on histopathological specimen, takes 5 days to come. Got it? Sorry, 10 days to come. And after that, you go ahead.
So the patient has gone for surgery. This would be only for stage 1 and stage 2.
And 3.
So
Clinical.
stage 1, 2, and 3
So if
clinical.
on PET scan it has not spread, go meet your surgeon and think about surgery, discuss about surgery. If it has spread, surgery is not an option for cure. That time surgery will be done only if you are constipated, if you are in obstruction. That time surgeon will say, your disease has spread everywhere. But since your colon is completely blocked by the tumor and you're not passing stool, I will have to do a temporary surgery like put a stoma or a bag so that you pass motion. And after that, you will be given chemotherapy. So that surgery is only for a diversion colostomy or a diversion for passing stool because you're not passing stool. And then that can lead to complications. But because it is already stage 4, it is not a curative surgery, it's a palliative diversion colostomy. So, surgery is done from stage 1 to 3. In stage 4, usually surgery, if you do, you're only doing as a diversion colostomy when you are in obstruction. Some stage 4 colon cancer patients, you will do a surgery. Why and when? Stage 4 means it is in the colon, and imagine it has gone to the liver. Suppose it has gone to 1 or 2 spots only in the liver, then what you will say, this is oligometastatic disease. That means your cancer is metastatic, but only in 1 or 2 areas. So in the same surgery, I will remove both. If it has spread to the entire liver, entire lung, multiple areas, then removing the colon will not help there. But if it is only 1, 2 areas of the liver, where it can be removed, you have a good general condition, then you will say your disease is stage 4, but still limited disease, not lot of disease. I can perform a surgery at both places in the same sitting, or today I will do surgery for the colon. After a few months of chemotherapy, I will do surgery in the liver. But that is only in the rare or few patients who have limited volume of disease called oligometastatic disease. If you have frank cancer everywhere, surgery is only done for diversion, for obstruction. It is not done for cure.
And for those patients who have a metastatic disease, how would you proceed with the treatment for those patients?
If they are fit clinically, if their general condition is good, they're able to do their routine activities. Chemotherapy plus targeted therapy is the treatment. Chemotherapy is the backbone, given once every 2 or 3 weeks for 6 months. Targeted therapy is based on analysis of the tumor for certain mutations: KRAS, NRAS, BRAF, HER2, MSI, etc. If they are all wild type, we say there is no mutation is seen, we add a targeted therapy called bevacizumab to this chemotherapy. If or a drug called panitumumab. If they have a mutation, we do not give panitumumab, we give bevacizumab. So don't, for our viewer, I don't want him to get or her to get confused. Stage 4, if you are giving chemo, it is for 6 months, every 2 or 3 weeks. You will send the tumor for certain mutations called colorectal cancer mutation profile. Based on that, your doctor will add a targeted therapy. All these are injections. Targeted therapy increases the patient's lifespan a little bit. Targeted therapy is added with chemotherapy. It is continued even after chemo is completed. So it has an advantage that some medicine is continuously going to the patient to keep the disease under control, and it has no chemo side effects. And targeted therapy will be given based on your mutation testing on your tumor.
Any recent advances which have happened for this cancer in terms of treatment?
The recent advances is, so some 40 years back, 5FU was the drug given. Lifespan used to be 6 months in stage 4. Then what happened? People added a drug called oxaliplatin, another 3-4 months. Another drug called irinotecan, another 2-3 months. Folfox, folfiri, folfirinox. This that is adding all these drugs. Then the targeted therapy. If you add targeted therapy, lifespan increases. Now it has become 1.5 year or one and a half to 2 years. There is a subset of colorectal cancer which is MSI high, microsatellite instability high. They do very well with immunotherapy. Responses are much higher than chemotherapy. No side effects like chemotherapy, and their survival is almost a double of chemo patients. So, what are the advances? Advances in screening, that is after 50 years, get a colonoscopy every 10 years. Advances in imaging, good MRIs and PET CTs. Advances in surgery, our surgeons have become very skillful now, and you have realized that you should remove 15 lymph nodes and not less, because if you remove less number of lymph nodes during surgery, it is bad for the patient overall. Advances in treatment, I told you all the chemotherapy drugs. Advances in mutation analysis or investigations like KRAS, NRAS, BRAF. If you are negative for this, you are given different drug. If you are HER2 positive, you are given trastuzumab. If you are MSI high, you are given immunotherapy. And obviously, the immunotherapy era has also begun. So these are all the advances which have occurred. And finally, advances in supportive care and palliative care. Even after all this, when they become very sick, when all their treatments are over, still they are taken care of well, because we have excellent pain medications, excellent anti-vomiting medications, etc.
There is a myth which people have that usually when you have like colorectal cancer or anything related to the GI tract, whatever cancer you have, and if you have performed or if you've gotten a surgery done, then you do not need to take chemotherapy.
So now this gentleman whom I told you, he has T3N0. That means stage 2. Stage 1, you don't need chemo after surgery. Stage 3, 100% you need chemo after surgery. Stage 2, some people need IV and oral. Some people need just oral. Some people don't need anything. So your chemotherapy after surgery is based on stage 1, no chemo, 3, 100% chemo, 2, few will require, few will not require.
Okay. And when we talk about the prognosis for the patients based on the stages, how is it classified? Is it good? Is it bad?
Good. Colorectal cancer is a good cancer. Many patients are picked up early. Early stages are highly curable. 5-year survivals for stage 1 and stage 2 are beyond 80-90%. For stage 3 is beyond 70%. Metastatic colorectal cancer, we used to think about survivals of a year. Now it is more than 2 years also, with good quality of life. So it's a reasonably okay cancer. Early stage is definitely wonderful cancer, curable, treatable. Surgery is the main treatment of choice. Chemotherapy added in certain situations to reduce recurrence when the benefit of chemo is absolute benefit is more than 5%, we say. So it's not a very bad cancer like a pancreatic cancer or gallbladder cancer in advanced disease also.
And sir, lifestyle recommendations for the viewers in order to not
Correct.
get colorectal cancer.
Healthy food, home food, preferably avoid outside food, avoid a lot of oil and all that stuff and spices and stuff, lots of green vegetables, fruits and fruit juices and that kind of a healthy diet. Do not skip your meal, eat on time, obviously stop smoking and alcohol and maintain a healthy body weight.
Sir, any parting messages before we end for today?
It's a common cancer, it's a highly curable cancer. Symptoms are pretty obvious like blood in the stool. Get yourself checked if you have any of these symptoms. The ideal test is a colonoscopy and a biopsy. And many times, if you're caught early, surgery is the treatment of choice. You may or may not require chemotherapy later. Yeah, and follow a very healthy lifestyle. Most importantly, diet, nutrition, exercise, and yeah, healthy body weight, and abstain from alcohol and smoking.
Okay, sir. Thank you for a wonderful session.
Thank you.